All right, welcome. Today, we are tackling a classic clinical puzzle, one that honestly challenges doctors every single day. And that is, how do you figure out exactly where a nerve problem is coming from?
Okay, so let's just dive right in with a super common scenario. Imagine a patient walks into your clinic. They're telling you they've got numbness, maybe some weakness in their hand, specifically around the thumb and index finger. So here's the big question. Is this problem starting way up in their neck, or is it something happening down in their wrist, like carpal tunnel syndrome?
So, right off the bat, we've got two main suspects in this medical mystery. First, you've got radiculopathy. Now, that's a fancy word for a problem with the nerve root, right where it pops out of the spine. The best way to think about this, it's like a problem at the main circuit breaker for your entire house. Then, suspect number two is neuropathy. This is when the nerve gets damaged somewhere further down the line, out in the arm. So, sticking with our analogy, this is like having faulty wiring in just one specific room. See the difference? Big picture versus localized.
Now, to solve this thing, you can't just guess, right? Clinicians rely on a really precise physical exam. And you should think of this exam as our investigator's toolkit. It's how we gather all the clues we need to piece this puzzle together. The whole investigation really boils down to three key steps. First up, we do a motor exam to test for power. Which muscles are strong, which ones are weak. Second, the sensory exam, where we carefully map out exactly where the numbness is. And finally, step 3, we check the reflexes. Each one of these steps gives us a crucial piece of the puzzle. Okay, so let's jump into our first set of clues, and this is a big one, decoding the sensory maps. Honestly, this is often where we get our first major lead in the investigation. And this is where things get really interesting because the critical difference all comes down to the patterns of numbness. See, a radiculopathy, that nerve root problem, follows a really broad strip of skin we call a dermatome. It's a wide, almost predictable pattern. But in neuropathy, that follows a much more precise, distinct territory of that one specific peripheral nerve. It's way more localized. So what does that actually look like? Well, if the problem is that C6 nerve root up in the neck, the sensory loss is going to follow that classic dermatome pattern. It's like a strip running right down the side of the forearm and into the thumb and index finger. But if the problem is actually the median nerve way down at the wrist, that numbness is going to be way more contained. It's locked into its specific territory in the hand. We're talking the thumb, index, middle, and about half of the ring finger. But notice it usually doesn't affect the forearm. The map is totally different. Okay, so that sensory map gives us a huge lead, a really strong hint. But to be sure, to really confirm where this problem is, we need more evidence. And that's where the motor clues come in, looking at the patterns of weakness and checking the reflexes. This is how we're going to lock in on the lesion's location. All right, let's look at this next set of clues. It's so telling. With the C6 radiculopathy, the weakness hits muscles that are supplied by that nerve root, and that includes muscles higher up the arm, like your biceps and some key wrist extensors. But with a median neuropathy at the wrist, the weakness is stuck down in the hand, in those little muscles that control your thumb. And here's a huge giveaway, the reflexes. They're going to be decreased with that C6 neck problem, but they're typically totally normal if the issue is just in the wrist. So you might be asking, why are those reflexes so darn important? Well, it's because a problem at the nerve root is a problem with the lower motor neuron system. It literally interrupts the electrical circuit, the reflex arc. The signal just can't complete that loop properly, and that's why the reflex is either weaker or completely gone. Okay, we have gathered all of our clues. We've got the sensory map, we've got the weakness pattern, and we've got the reflexes. It's time. Let's review the evidence from our patient and solve this clinical mystery once and for all. So, here's the case file. Here's what we found. Our patient has numbness right in that classic C6 dermatome pattern. Check. They've got weakness, and it's not just in the hand. It's in wrist extension and in the biceps muscle. Check. And then the smoking gun, a decreased biceps reflex. Checkmate. This is really the crucial takeaway. All the major pieces of evidence are pointing upstream. That biceps weakness and that changed reflex, there's just no way a problem isolated to the wrist could cause that. The source of the trouble has to be further up the arm, way closer to the spine. So, when you put all of this together, the motor findings, the sensory map, the reflex changes, we can diagnose this with a ton of confidence. This isn't a peripheral neuropathy down in the wrist. The diagnosis is a C6 radiculopathy, starting all the way up in the neck. So there we have it. We've used our clinical reasoning toolkit to solve the where. We've pinpointed the location. But in any good investigation, that just leads to the next big question. How do we get definitive proof? And how do we figure out the why?